Hi, I'm Brian Kiss, and I run the accountable care business for Florida Blue, where we insure about 4.5 million people. My background is I had a career in finance before I became an academic nephrologist and spent most of my career in the Columbia University system prior to transitioning over to the dark side of the payer world here. So what I think we need to do, we've talked about the advances in cancer and the way this care has been delivered. And one of the things we really need to do is to really take a look at the cost here. These are wonderful advances, but this stuff is really, really expensive. So the first thing I really want to do is to really take a look at the magnitude of the issue we are talking about. So let's just start out with the first thing. GDP, $15 trillion, $16 trillion. Huge part of that is medical care in general. It's up to about $2.8 trillion, moving fast to $3 trillion a year, which is going to be spent on health care. That is 17 to 19% of GDP. It's larger percentage of GDP than any other developed country spends on health care. Our per capita costs for total health care in the United States are about $8,000 per person. Western Europe is delivering similar care, very similar quality, outcomes at least as good, and they're delivering it for roughly $4,000 per person. So we're looking at a system which costs twice as much as the rest of the developed world, with results that clearly aren't twice as good. And so that's part of the financial issue. Now, health insurance in this world, you heard from Dr. Conway, public payers are a big part of it, but still the majority, greater than 50% of it, is being paid for by private sources and us in the healthcare industry. Okay, so what does this relate to oncology? The percentage of our health spend in Florida for oncology, it's the single largest component, especially if you add in the cost of screening. Screening isn't cheap, and the cost of treatment on top of it. It is roughly 25% of total healthcare cost. So you're looking at this thing, the country is spending $3 trillion a year in healthcare cost, and it's a little bit more in the commercial area because of, as people get older in Medicare, the cancer percentage the demographics are a little different, but it's about 25% in the under 65 population that the cost of health care is just for cancer. So it's a big problem that we have. Okay, so we've talked a little bit about it on a macro level. How does that translate to an individual? These cost issues of these wonderful advances that we're seeing. Let's just take a family of four, and let's take the traditional model, which is still mom and dad go to work, and they've got employer-sponsored health care. Got a family of four, 2 kids, golden retriever. The cost of health care, total cost of health care for that family, depending on the source you look at, is somewhere around $20,000 a year. $20,000 a year. And of that $20,000, roughly $5,000 is going to oncology. It is huge. This is a huge burden for people. Now, what is the meaning of that? If we look at businesses, say you're a business owner, and we're really a service economy. If you run a service-oriented business, the largest cost of doing business is typically the salaries of your employees. The second cost is the health care benefits that you provide to your employees. So we are taking a huge amount of funds in this country away from as businesses participating in this, and that's funds to run their business. It affects their profitability, it affects their ability to reinvest in their business, to grow jobs, and it affects their ability to grow wages. We have a stagnant wage economy. Healthcare in general is a drag on the economy, and oncology care is a big part of that, and we really have to address the issues. So you've heard a little bit about what's been done in the public sector from Dr. Conway. I'm going to just try to talk a little bit about what we did in the private sector and what our approach has been to it. Just a couple of examples of what's going on here. And so the first thing we did, we recognized, okay, oncology is expensive. We've got to take a look at it. Let's go to the data. And the data kind of impressed us like this. The data around oncology is particularly opaque. A payment system has evolved for oncologists, where its typical compensation traditionally has been something called buy and bill. Many oncologists derive most of their income by buying drugs and then infusing them at a profit margin for their patients. So basically, much of this is based on the oncologist's ability to run a profitable retail pharmaceutical business in their office. That's been a common model. And if you look at there is a total lack of transparency in the pharmaceutical industry about pricing of drugs. So it's very difficult to know what is actually being paid and where the profits are. It really is a difficult thing. That's just one issue. Dr. Nelson mentioned about that they didn't have good staging data when you look at a major medical center where people are referred in. So we want to know, what are we paying for? And we did a pilot study. We have a great academic medical cancer center in Florida, Moffitt Cancer Center, and we looked at their data we looked at it with them. And you mentioned 26% or 27% in pancreatic. They looked at all diagnoses going in there. They came close to 30%. So we're trying to figure out what we should be paying for stuff, and we're not sure what the tissue diagnosis is. We're not entirely sure what the staging is from our claims, and our claims data is not nearly as good as the clinical data in charts. So we're kind of like the blind man on the elephant. We're feeling the little pieces we have and trying to figure out what's really going on out there. It has been very, very difficult. Cancer care, particularly as addressing in cost, has been a particularly difficult thing. Try to figure out the cost of something like a total knee replacement. I know that to the penny in Florida. I can build a bundled payment system around that really easily. But when you look at cancer care, you look at the variability of care. Now, what should it cost going forward? Dr. Shilsky talks to you about all these wonderful advances, molecular medicine. Those drugs are incredibly expensive. What is going to be the benefit? What should the cost be? Should it be single therapy? What should we expect? What should the expectations be in this rapidly changing world? The scientific data is overwhelming to really try to figure out what we should be paying and what we really should be doing to patients. So I think one of the things is we all recognize that cancer care is a problem, and we've been talking a lot about it in private payers. We go, well, what are you doing about oncology? It's a big part of your cost. I don't know. And so what I'd like to do is just show you some of the approaches that we have taken in the industry. First of all, there's a traditional approach, which is utilization management, which is the idea that the insurer finds that this stuff is expensive. Maybe we can figure out a way that some of this might not really be necessary and we can do less stuff. Or maybe if they're doing expensive stuff, maybe we can push them to an alternative and do less expensive stuff. This is what we call utilization management. And what it creates is this environment. And that's the slide. It's Mother May I. Poor guy in his office wants to treat his patient. He's got to call somebody up. This person may not know his patient, clearly does not know his patient, may not have the specific expertise he has, but you're looking at this whole process where you have to ask permission. We also have things like limited formularies, especially around oncology drugs, certain key expensive oncology drugs, marrow stimulating agents. We have a narrow formulary, and you have to ask permission to give certain doses above certain targeted levels. And what happens with this? Number one, the providers don't like us. They don't like asking for permission, and it really has eroded the relationship between payers and providers around the country. But there's a real administrative burden to it. We know that in a primary care practice, I don't have good data for oncology practice specifically, but in a primary care practice in the United States, for every hour that a primary care physician sees patients, actual patient care, they generate roughly 15 minutes of physician work to meet the requirements of managed care. That's calling back, doing these things, doing the paperwork, sending records for billing purposes, all of those other things that we do for managed care. So we've created an administrative burden. And this is what we've been doing for 30 years. And how well did that work? You saw my first slide, we're spending $3 trillion a year, and that's what we've been doing. Hasn't worked well. So that's where there's all this, right now, the current enthusiasm for new payment models. And this is, so let me just show you what we're doing and what some others are doing. First, pathways. Pathways are something which we as a company, or my team, has really not pursued. The way the pathway structure comes, and the way, not to say that it's not very valid clinically, which one can argue how do you make a valid pathway with all this new personalized medicine? These are standardized things. There are some issues about it, but in general, it's a good idea. It standardizes care, gets people in evidence-based pathway, in evidence-based treatment programs, rather. So it's probably a good thing. But one of the things is, how do you build a payment program around it? And for years, oncology groups have been coming to me, and they've been saying, look, we'll do pathways, You send me a check, and at the end of doing the pathway, we know care will be better, and we know it'll be less expensive, and you'll win. So you basically pay for a process, hope that that pathway in turn does give you real cost savings and real quality improvement, and that's the program. It's kind of pay and pray to some extent. So you pay ahead of time, and you hope that you get the results. So I kept on going like, okay, if the results are improved quality, we can come up with some measures we both can agree, and those will be the quality measures for a program. And cost, I can measure that because I write the checks. So I know what this stuff costs. So why don't we just do a program that goes to the back end directly and build a program directly around cost and quality? So what Pathways have done, there's one major payer right now that is just started, just one program I can talk about, and that is WellPoint. WellPoint has a pilot now in 6 states. It's for breast, lung, and colon cancer. And what they do is if you put a patient on Pathways, they send you $350. And then they give you a monthly stipend in addition. It depends a little bit on region and whatever, almost another $350 a month to stay on that pathway for the months of treatment. And it's addition to fee for service. And they hope that at the end of that process that they will reduce costs and achieve quality standards. So it's basically, that's what they're doing. It's out there in 6 states, just really formally started up, I think July 1. So that's really what that's one approach. And so they are using the pathways directly. But what the approach that we took is really more on the ACO basis. And we did this in 2 ways. We created 2 cancer ACOs intentionally. We created the first cancer ACO in the country in Miami with a very large community hospital system. It's an excellent community hospital system. If you look up that, the standard quality ratings are always one of the top in the country. And it had a large captive private oncology group, which had an exclusive contract to work with them. Did all of the radiation, radiation and clinical oncology. So we created a program with them in Miami, and we did that about 1.5 years ago. And we did it about the total cost of care of cancer. We set up a whole series of quality measures they had to meet. We looked at what the population cost had been for the past 2 years, projected that forward with an inflation factor, said that's your target. If you can bring in the care below that, we'll split the difference with you. If you bring it in below your target and you do it, they hit their target, they hit their quality measures. So we've saved a couple of $1 million, and the patients got reasonable quality care. Now, what we did in that, by doing that, with the pathways focused largely on what tests do you do, what drug do you do, at what time, it really takes in the totality of care. It takes in things like care management, it takes care, office access. Do you have, when a patient is having side effects of chemotherapy, what happens when you call the office? Do you say, okay, go to the emergency room, they'll plug you into an IV? Or do you say, come to my office and we'll take care of you? Very different sites of care, very different level of patient convenience, and in the long run, very big differences in cost. So the model we chose to do is to take in this total cost of care model rather than focusing on pathways specifically. You'll hear more about pathways from subsequent speakers. So that's the approach we did. The other approach that we take is we really are looking at total cost of care models, and we're looking at them across populations. So if I go to a major medical center, we have now 14 of these models up in the state of Florida, and under these arrangements, I have 800,000 patients under these arrangements right now. And as you look at these arrangements and you say, look, oncology care, if you're looking at a whole population for all conditions, if oncology care is 25% of that cost, and you're working with us to help manage cost, oncology gets to be a very expensive thing, a very expensive part of it, and let's work with you under these systems to take down your oncology cost as part of your cost savings under the larger program. So by doing that, we've wrapped people into the ACO, general ACO model, and we have 2 cancer ACOs. At this point, we're going to run those cancer ACOs. We may bring in 1 or 2 more, but we're really looking to really bring these patients largely into these all diagnosis, all condition ACOs, and to work with our provider partners in terms of saying, look, let's work on some of the oncology. Let's take the lessons learned from other systems. Let's take the lessons we learned. One of our partners is Moffitt Cancer Center. That's our other ACO, big academic center, very much like the Hopkins Cancer Center, not quite as prestigious, but a large one that we're working with. So they've developed their own pathways that they're going to help share with us. Another system. So it's very interesting that both our partners, both the Miami group that we have and the Moffitt system, are using pathways to achieve this end, but we're not paying for the middle. We're not paying for the process. We're not focusing on the process. We're really trying to focus on the outcomes of cost and quality. That's what we do. The data are fairly early. Both our systems have met their cost targets right now. They've met their quality targets. I can say what a little bit more mature is our general ACOs and our patient-centered medical homes, and which also manage these patients. And we are seeing things like about a 3% cost reduction overall, which is pretty good. We're seeing a marked quality improvement, and we're also seeing things that are very important in terms of ER reductions in ER utilization, reductions in hospitalization, and about a 10% improvement in patient satisfaction. So, the way we've approached it has been to take these endpoints, get away from measuring process, and really try to focus on outcome-based programs for us. And hope to be able to give you more results as we go on.